Hello everyone. Our topic of today's discussion is renal tubular acidosis. So, starting with RTA. So, how do we define RTA? What is RTA? So, RTA is defined as a group of disorder in which there is defect in renal tubular function which result in acid base imbalance and electrolyte disturbances despite having normal GFR. So, in this disorder, GFR is totally normal. There is defect in some renal tubular function which result in acid base imbalance like metabolic acidosis and electrolyte disturbances like hyperkalemia or hypokalemia. So, to make it more practical, we'll start with two real case scenarios. The first case is 6-year-old boy presented with complaint of poor weight gain, deformity of the leg and persistent bedwetting. Labs is pH slightly on the acidic side, bicarb with a bicarb of 16 on the lower side and PCO2 of 30. So these value going on the same side. So this is metabolic acidosis. Since anion gap is sodium 139 minus chloride plus bicarb which is equal to 5. So this is normal anion gap metabolic acidosis. Next is serum creatinine is normal and the spot urine test shows this value. We'll calculate urine anion gap whose formula is sodium plus potassium which is different from the blood anion gap minus chloride. This is 45 plus 22 minus chloride is 15. 67 minus 15. 52. And the urine pH is 4.2 which is slightly on the acidic side. We'll discuss everything. So in this case, a young boy with these symptoms having normal anion gap metabolic acidosis and hypokalemia, having normal GFR, normal serum creatinine, having positive urine anion gap and urine pH is on slightly acidic side. Now, keep everything in mind. We'll discuss this case at the end of our discussion. Now coming to our next case. Second case is 28-year-old female presented with complaint of generalized weakness and fatigue, recurrent muscle cramps and flank pain. Lab value is pH slightly on the acidic side with a bicarb of 14 which is also on the lower side with a PCO2 of 30 which is also on the lower side. So this is also a metabolic acidosis. Anion gap is this comes 12 which is also a normal. So this metabolic acidosis is also normal anion gap metabolic acidosis. In normal anion gap metabolic acidosis, the decrease in bicarb is compensated by increase in chloride. That's why this is called normal anion gap metabolic acidosis. In this, the serum creatinine is also normal, urine anion gap is positive and urine pH slightly on, this is also acidic but slightly on the upper side. So can you spot what is common between these two cases? In both the cases, there is NAGMA, normal anion gap metabolic acidosis. What is common between these two cases is both having NAGMA, normal anion gap metabolic acidosis plus hypokalemia. This is common between these two cases. So in all the cells of the nephron, there is asymmetrical distribution of the channel proteins which creates gradient which further drives transport. For example, we have sodium potassium ATPase. We'll understand with the example. Suppose this is a cell of nephron. This is the apical membrane, this is the basolateral membrane and this is the another cell and this one is the lateral membrane. This is the lateral membrane attached with a tight junction. This is the lumen and this is the interstitium. So I told you there is asymmetrical distribution of the channel which creates gradient. So we have sodium potassium ATPase. For example, we have sodium potassium ATPase on the basolateral surface, which throws 3 sodium outside and brings 2 potassium inside. Overall, it throws 1 extra positive ion outside. So this creates a negative gradient inside the cell, which helps to bring 1 extra positive charge, which can be sodium or any positive charge inside the cell. So because of asymmetrical distribution of this channel protein, it created a gradient which helps to bring the positive ion inside the cell. So because of this asymmetrical distribution of the ion, now we will discuss the 2 type of transport occurring inside all the cells of the nephron. First one is paracellular pathway. The another one is transcellular pathway. So what are these pathways? Suppose this is the nephron. This is another cell of the nephron. This is the luminal side. This is same interstitium side. This is the apical membrane. This one. This is the basolateral membrane. And this is the lateral membrane. We already discussed, attached by a tight junction. So the 2 lateral membrane attached by a tight junction are actually not tight. They are actually leaky. So majority of the transport occur through this pathway. This is called paracellular pathway. This is actually a passive process. Now another pathway is transcellular pathway. If the transport occurs through the cell, this is called transcellular pathway. This transcellular pathway can be active and can be passive, but this paracellular pathway is a passive process. So majority of the solute and water occurs through this paracellular pathway. Now coming to the transcellular pathway, cellular one. So because of distribution of the asymmetrical channel ion, for example, sodium potassium ATPase, which throws 3 sodium outside and brings 2 potassium inside. Because of this, it created a gradient. So these active transport, we call this as pump. Because of pump, it created a gradient. Across this gradient, now ion will move. So the ion will move by 2 processes. First one is simple diffusion. Simple diffusion, just from high concentration to the low concentration. These are called as channels. We call these as channel. And the second mode of transport is down the gradient only, but these are secondary active transport. Why we call this as secondary active? Because this is coupled with sodium ion. So this secondary active transport can be co-transporter or antiporter. If it is co-transporter, then we have 3 transporter in PCT. First one is sodium phosphate. Second is sodium glucose. We call it as SGLT2 transporter. And the third one is sodium amino acid. These all 3 present in PCT, proximal convoluted tubule. So any defect in PCT, will cause phosphate urea, glucose urea, and amino acid urea. So wasting of phosphate, glucose, and amino acid occurs in Fanconi's syndrome because there is defect in PCT, global dysfunction of the PCT. Now coming to the antiporter. In antiporter, what happens is there is exchange with sodium ion. For example, if the sodium ion goes outside, a hydrogen ion will come inside. This is antiporter. So summarizing these two things, first one is paracellular pathway. Paracellular pathway is a passive process. Majority of the solute and water occurs through this. This occur between the two cell, between the tight junction. And the second one is transcellular pathway. Transcellular pathway is across the cell. This across the cell. This can be active or passive. Active or passive. So we will now discuss each part of the nephron individually, starting with proximal convoluted tubule. So we already discussed there are two type of transport. First one is paracellular pathway, in which majority of the solute and water, solute like calcium, potassium, magnesium occurs through this transport. This is a passive process. The second one is transcellular pathway across the cell, in which there is a pump which creates a gradient like sodium potassium ATPase. This pump creates a gradient, and across this gradient ion moves by two processes. First one is diffusion, which is simply from the high concentration to the low concentration, and the second one is secondary active transport, which is very important. We will discuss secondary active transport. In secondary active transport we have either co-transporter or antiporter. Starting with the co-transporter. In co-transporter, the ions move coupled with sodium. This is co-transporter, in which the sodium moves with phosphate. This is a type of co-transporter. This is also a type of co-transporter in which sodium moves with glucose, which we call as SGLT2 inhibitor, SGLT2. And the third one is sodium coupled with amino acid. So in PCT we have three type of transporter. First one is sodium phosphate, the second one is sodium glucose, and the third one is sodium amino acid. In amino acid, majority of amino acid is CoA, cysteine, ornithine, lysine, and arginine, CoA amino acid. And the transporter, name of the transporter is SLC31A, 3A1 and SLC7A9. The defect in these channel protein causes cysteinuria. And the second one is sodium glucose. The defect in this causes normoglycemic glucoseuria. And the inhibitor of these channel protein is glyphlogens, canagliflogens. And the first one is sodium phosphate. Defect in this ion channel protein causes phosphaturia. Note, phosphate is majority of the phosphate ion is absorbed by the PCT only. So defect in PCT causes phosphaturia, which is the reason for development of the rickets. Now we already discussed the symporters, co-transporter or symporters. Now coming to the antiporters. In antiporters there is moment of a positive ion like sodium in exchange with a positive ion like H+. So this antiporter helps in acidification of the urine. So this antiporter helps in acidification of the urine. So this is sodium and this is H+. This H+ combines with either ammonia to form NH4+. This is excreted. or this H plus combines with S2 SCO3 bicarbonate to form S2CO3, which convert to H2O plus CO2 with the help of enzyme carbonic anhydrase, and this CO2 moves inside the cell, CO2, which again combine with water to form S2CO3, again S2CO3 dissociate into H plus and SCO3. This H plus moves out with the symporter. So if there is defect in this antiporter, will lose bicarbonate. So this will lead to metabolic acidosis. We won't be able to absorb bicarbonate. Okay, so coming to the next part of the nephron, which is thick ascending loop of Henle. So again we have two type of transport. First one is transcellular pathway, in which solute like potassium, magnesium, calcium absorbed passively through the channel protein known as claudin. This is again a passive process. So a defect in claudin protein, this claudin protein causes hypomagnesemia, hypercalciuria, and nephrocalcinosis. Okay, now coming to the second important pathway, which is transcellular pathway. We already know in transcellular pathway there is a pump which creates a gradient inside the cell, which is sodium potassium ATPase. Utilizing this gradient, ion moves inside the cell. So in THAL we have important channel protein known as NKCC2. Through this channel, 1 sodium, 1 potassium and 2 chloride moves inside the cell through this channel utilizing this gradient. So 1 sodium, 1 potassium and 2 chloride. To further maintain the electrochemical gradient inside the cell, these potassium passively diffuse out of the cell and these chloride passively diffuse out of the cell through a channel protein. The name of this potassium channel is ROMK. Important. This ROMK. And this chloride also moves out of the cell. Chloride channel. So the defect in this first one, NKCC2 channel protein, causes type 1 Bartter syndrome. The defect in this ROMK channel causes type 2 Bartter syndrome. And defect in this chloride channel causes type 3 Bartter syndrome. We also know that the Lasix or the furosemide inhibit this channel protein, which is sodium potassium 2 chloride channel. We'll discuss this topic again in detail. Coming to the next part of the nephron, which is distal convoluted tubule. Actually, the distal DCT is divided into two parts, which is early DCT and late DCT. Early DCT is actually similar to thick ascending loop of Henle, as they both are impermeable to water and urea and permeable to solute, And the late DCT is actually similar to cortical collecting duct. So we will discuss these two under the same topic. Now coming to the early DCT. Like other nephron, we have this cell. This is apical membrane. This is basolateral surface. This is the luminal side. This is the interstitium side. Like other nephron, we have one active transporter called sodium potassium ATPase, which throws 3 sodium outside and brings 2 potassium inside the cell. Again, this creates a gradient inside the cell. So down this gradient, one sodium and one chloride moves inside the cell using this symporter. Since this chloride came against the gradient, it will diffuse out. So coming to one more active transporter we have in early DCT, which is calcium ATPase. This is very important to remember. In early DCT, apart from sodium potassium ATPase, we have one more transporter, calcium ATPase. So what it does is it helps active reabsorption of the calcium from the basolateral surface. Again, it creates a gradient inside the cell. So from the luminal side, there is absorption of the calcium. And one more transporter is located in the basolateral surface, which is calcium sodium antiporter. Why this is important? Because this is the site where PTH, parathyroid hormone, acts and it increases the calcium reabsorption. So total 5 to 10% of sodium reabsorption occur in DCT. So now coming to one more important point, which is this one. This is the transporter where the exon of thiazide happens. So the diuretic thiazide acts on this transporter, which actually blocks this transporter, which helps in loss of sodium and chloride in the urine. So one more thing, if there is genetic defect in this transporter, then this syndrome is called Gitelman syndrome, which is a autosomal recessive disorder. Now coming to the late part of the DCT. Actually, late part of the DCT and the cortical collecting duct are very similar. So we will discuss these two together. So combining these two, we have two type of cells located in early DCT or cortical collecting duct. First one is P cell, which is called principal cell. And the second one is intercalated cell. The first principal cell is actually more concerned with electrolyte management, like sodium potassium reabsorption. And the intercalated cells is more concerned with the acid base reabsorption. So coming to the first P cells. So like other nephrons, we have sodium potassium ATPase on the basolateral surface. This is the apical membrane. This is the luminal side, and this is interstitium. So again, this sodium potassium ATPase creates a gradient inside the cell. So this sodium moves inside using a channel called, very important, ENAC channel. Since this potassium moved inside, so it will diffuse out into the lumen. One more thing to remember is that there is receptor of aldosterone in this part of the nephron, P cell, which increases the function of this sodium potassium ATPase. So there is overall aldosterone causes more reabsorption of sodium, and there is loss of potassium, loss of K+. So it will cause hypernatremia and hypokalemia. Now coming to the intercalated cell. We have two type of intercalated cell. First one is type A. type A, which actually helps in acidification of the urine. Actually, the type A and type B are, the function of these two are just opposite. So the transporter are located just opposite. We'll discuss in detail. So coming to the intercalated cell type A, which helps in acidification of the urine. Again, we have nephron. This is apical, this is basolateral, this is interstitium, and this is lumen. So what happens is, the CO2 moves inside the cell. CO2 and H2O combine to form H2CO3. This dissociate to form H plus and HCO3. So I told you that this type A cell helps in acidification of the urine. So we have a transporter. Using active transporter using ATP. It pumps out one H plus inside the lumen. So it is helping excretion of the H plus. It is helping in excretion of the H plus. And we have one more active transporter, which is called H plus, K plus, ATPase in the apical membrane. This is important to remember that we have two active transporter here. One is H plus ATPase, which helps to pump H plus inside the lumen, and another active transporter, which is H plus K plus ATPase, which helps to pump H plus and K plus inside the lumen. So this part of the nephron is important for acidification of the urine, or helps in excretion of the H. Thing to remember is, here the H plus secretion is active process, whereas in PCT, if you remember, it is an passive process. One more thing, the last thing is कि HCO3 diffuses out of the cell in exchange with chloride. CO3. This is the intercalated cell type A. So now coming to the type B intercalated cell, it does opposite to type A. So the transporter are located opposite to type A. Similarly, CO2 comes inside the cell. CO2 combines with H2O with the help of carbonic anhydrase to form H2CO3. Again, it dissociates into HCO3 and H plus. We have H plus ATPase located on basolateral surface here, not apical. So it helps in absorption of H plus, and CO3 SCO3 moves out of the cell and it gets excreted here. Note one more thing is to be noted is we have one receptor on the alpha cell or type A intercalated cell. The receptor is aldosterone receptor. So it actually increases the function of this H plus ATPase. It helps in secretion of the H plus ion also. Now we have discussed all part of the nephron. One more thing we have to remember is virtually late DCT and cortical collecting duct are impermeable to water, H2O, without ADH. When ADH acts on these part of the nephron, it creates a aquaporine which helps in H2O reabsorption. So this area is under control of ADH, which controls the dilution or concentration of the urine. Now one more part of the nephron, for the completion sake, we have one more part of the nephron, which is medullary collecting duct. What happens in this part is H2O reabsorption, secretion of H plus against gradient, like we discussed, cortical collecting duct, and the third one is it transports urea transport. So urea, it helps to move the urea into the interstitium, which helps to maintain the counter current multiplier. So this is all we had to know in in the physiology of the nephron. Now coming to the renal tubular acidosis. So starting with our main topic of discussion, which is renal tubular acidosis. So we already discussed there is defect in renal tubule in RTA. There is defect in renal tubule which causes metabolic acidosis, normal anion gap metabolic acidosis with electrolyte disturbances like hypokalemia or hyperkalemia. So we classify RTA into three types. First one is type 2 RTA. Type 2 RTA, there is defect in proximal nephron, PCT. There is defect in proximal nephron. In type 1 RTA, there is defect in distal nephron. These type 2 and type 1 present in much similar way. They both have normal anion gap metabolic acidosis and hypokalemia. So we will discuss these two topics along with. So third one is type 4 RTA. This is due to defect in collecting duct. This causes metabolic acidosis with hyperkalemia. We'll discuss this one separately. So coming to our first type 2 RTA, which is proximal RTA. We have already discussed this one. The proximal RTA helps in bicarbonate reabsorption. This bicarbonate reabsorption occur in proximal convoluted tubule. How this happens, we'll go through quickly. So this bicarb combines with H plus in the lumen. This H plus in the lumen, it forms H2CO3 with the help of carbonic anhydrase type 2. This is important to be remembered. H2CO3 dissociate into H2O and CO2 with the help of carbonic anhydrase type 2. This CO2 diffuses into the cell, which again combine to form H2CO3 with the help of carbonic anhydrase type 4. This inside the lumen, in the lumen, carbonic anhydrase type 2, and in the cells there is carbonic anhydrase type 4. So again this H2CO3 dissociate into H plus and SCO3. SCO3 moves into the blood vessel from the basolateral surface, and this H plus moves into the lumen with the help of a antiporter, sodium H plus antiporter. Why this moves? Because of gradient created by sodium potassium ATPase. We already discussed these things. These pump created a gradient by throwing 3 sodium outside and bringing 2 potassium inside. Overall there is negative charge inside the cell, so it brings extra sodium inside and it throws H plus outside. So this H plus again combined with H2CO3. So if there is defect in, so overall what happened is, but this bicarbonate in the lumen got absorbed into the blood vessel. So if there is any defect anywhere in this pathway, it will lead to proximal RTA. Now coming, so as we know, the proximal RTA, there is defect in proximal convoluted tubule, but the collecting duct is intact. So in PCT, due to defect in PCT, there is loss of bicarbonate which causes metabolic acidosis, and this bicarb goes to distal convoluted tubule. So we know distal convoluted tubule is intact, and this is responsible for the acidification of the urine. So the urine acidification is preserved because the collecting duct is intact. There is defect only in the proximal convoluted tubule. So urine pH is less than 5.5. Now the loss of bicarbonate leads to metabolic acidosis. but the acidosis is mild. Why? Because the collecting duct is intact, which is responsible for the acidification of the urine. And our body also tries to compensate this metabolic acidosis by decreasing the filtered load. So overall, because of these type of mechanism in adult or in child, the acidosis is very mild. Acidosis is mild. So now what will this acidosis cause? This acidosis, if there is acidosis in the body, it helps in calcium resorption. And second is, because of acidosis there is fluid loss, and this leads to activation of secondary RAS. Secondary RAS activation leads to hypokalemia. But these two manifestations require acidosis to be severe. But here the acidosis is mild, so these manifestations are rarely seen in proximal RTA. These manifestations are rarely seen. The problem comes when the issue is with child. So when a child presents with proximal RTA, even with mild acidosis, there is growth retardation. In the child. So we will now quickly discuss the causes of proximal RTA. In child, one more thing is, it is mostly associated with Fanconi syndrome. What is Fanconi syndrome? In Fanconi syndrome, there is global dysfunction of the proximal convoluted tubule. So along with normal anion gap, metabolic acidosis, along with hypokalemia, there is loss of glucose in the urine, there is loss of amino acid in the urine, there is loss of phosphate in the urine. So because of this, there is growth retardation, and because of loss of phosphate, there is associated rickets in the child. So a child presenting with nagma, hypokalemia, growth retardation, and ricket-like manifestation, you have to suspect renal tubular acidosis type 2. So now coming to the causes of RTA, causes of proximal renal tubular acidosis. First, we will classify these as majority of proximal RTA is associated with Fanconi syndrome. So those associated with the Fanconi syndrome and those without the Fanconi syndrome, we will classify as proximal RTA as those associated with Fanconi syndrome and those associated without Fanconi syndrome. So those associated with Fanconi syndrome is either inherited or acquired. Inherited, mostly present in child, like cystinosis, Wilson's disease, or galactosemia. In acquired causes, it can present in adult as, for example, patient is having multiple myeloma. It can present as proximal RTA. Or patient is on certain drugs like cisplatin, ifosfamide, streptozocin, or tetracycline. Or drugs like lead, or poisoning like lead, cadmium, or mercury. And in post-transplant patient also. So in acquired, we have 4 causes. First one is multiple myeloma patient, can present as proximal RTA. Patient is on drug, cyst drug, or poisoning patient, lead, cadmium, mercury poisoning, or post-transplant patient. So majority is associated Fanconi's syndrome only. Now those patient without Fanconi syndrome can present as, if there is deficiency of the carbonic anhydrase enzyme, and if the patient is on certain drug like acetazolamide and topiramide. Acetazolamide is commonly prescribed for mountain sickness, and topiramide is for prophylaxis of migraine or seizures. So in child, mostly associated with Fanconi's. There can be acidosis because of volume depletion. There is activation of secondary RAS which can cause hypokalemia. So hypokalemia with normal anion gap metabolic acidosis, there is phosphate wasting which can present like rickets and euglycemic glycosuria because there is SGLT2 transporter in PCT. We already discussed these things. So now summarizing, proximal RTA, which is type 2 RTA, the acidosis is mild, hypokalemia is mild, stones are rare because acidosis is not very severe, which does not lead to calcium reabsorption. So this is also rare, except, this is very famous question, except the patient is on certain drug like topiramate. In this, renal stone can be seen. So do we need to treat a patient with proximal RTA? In adult, there is no need of any treatment because the patient is in the steady state. Suppose with a bicarb of 18 and pH of 7.32 ऐसा करके. So the patient is not symptomatic, so there is no need of any treatment of proximal RTA in adult without any symptoms. In child, there is growth retardation because of even mild acidosis, so we can treat with alkali. The dose is 5 to 50 milliequivalent per kg per day. So now coming to the next topic, which is distal RTA or type 1 RTA. This is the alpha intercalated cell. We already discussed this. In this, there is active secretion of H+. There is active secretion of H+ by H+, K+ ATPase, first one, and there is active secretion of H+ by H+ ATPase. So these two are pump, first one, second one. So where does this H+ comes from? So CO2 comes inside the cell, CO2 combined with H2O to form H2CO3. This H2CO3 dissociate to form H+ and CO3, SCO3. These H+ is actively secreted by alpha intercalated cell by two type of pump. First one is H+ K+ ATPase and second is H+ ATPase. And this bicarbonate is exchanged with chloride through a anion exchanger 1. The name of this transporter is anion exchanger 1. So the defect in distal RTA is in either of the 1, 2 or 3. First one is H+ K+ ATPase, second one is H+ ATPase, and third one is chloride bicarbonate exchanger, which is also called anion exchanger 1. So we'll quickly go through the causes of distal RTA. First one is genetic cause. Which can be due to H+ ATPase, which is a pump. The disorder affecting this is autosomal recessive. This is most common type of, and it is actually of two types. The type in which there is B1 subunit defect, it is associated with SNHL, sensorineural hearing loss with RTA. You have to remember this one. Now coming to the next pump, which is H+ K+ ATPase. There can be defect in this protein which can lead to distal RTA. The third is bicarbonate and chloride antipoter, which is anion exchanger 1 defect, which is autosomal dominant. So genetic defect can affect any of these three protein channels or pump. First two are pump and the third one is channel. So now what are the acquired causes of distal RTA? First one is Sjogren's. This is very important. Second one is primary biliary cirrhosis. Third is some kind of drug, and fourth one is tolvine. So now we will move to the mechanism. What actually happens in the distal RTA? So we already discussed there is H+ secretion. H+ secretion is defective in the lumen, is affected. So the acidosis is more severe in distal RTA as compared to proximal RTA. Why? Because most of the acidification occur in collecting duct by alpha intercalated cell of collecting duct. So acidosis is more severe in distal RTA. So because of acidosis, because of acidosis, more severe acidosis, there is volume depletion. Because of volume depletion, there is activation of RAS, which leads to hypokalemia. And second, because of severe acidosis, there is calcium reabsorption from the bone, so which leads to hypercalcemia, hypercalciuria, and nephrocalcinosis. As there is defect in collecting duct, and we know collecting duct is mainly responsible for acidification of the urine, so the urine pH is more towards the alkaline side. In proximal in type 2 RTA, we know it is less than 4 or 5. It is more in the acidic side. But here the collecting duct, the urine pH is more than 5.5. So when an adult patient presents with hypokalemia and normal anion gap metabolic acidosis, you have to suspect type 1 RTA more than type 2 RTA. If there is some doubt, then you can measure fractional excretion of phosphate, because phosphate is primarily reabsorbed from the proximal convoluted tubule. If this is positive, then it can be type 2 RTA. So now, next is why there is nephrocalcinosis in distal RTA or type 1 RTA. Because of acidosis, there is increased calcium resorption from the bone because of severe acidosis. And there is second factor is there is hypercitraturia. Because of acidosis, body wants to absorb more bicarbonate. Along with bicarbonate, it absorbs citrate also. So in alkaline pH, which type of stone formation occur? It is calcium phosphate. We already discussed this. So how do we treat? Because of acidosis is severe, we have to treat this disorder with alkali. The dose of the alkali is 1 to 2 milliequivalent per kg per day. For 70 kg man, it can be 70 to 140 milliequivalent per day alkali. It is available in salt solution. Available as salt solution. Now coming to next part. Coming to the last RTA, the only RTA which is associated with hyperkalemia. So again this is principal cell of collecting duct. Now in type 4 RTA, there is defect in aldosterone. There is defect in function of the aldosterone. Somehow aldosterone is not able to function. So this ENaC protein, which is whose function is to reabsorb sodium from the lumen into the cells. So this is not working. So what will happen? There is increased sodium inside the lumen. There is increased positive charge inside the lumen. Because of increased sodium in the lumen. So because of this potassium, any positive charge will not come inside the lumen. This H plus, any positive K plus will not come inside the lumen, and this H plus HCO₃ resorption will not occur. So because of deficiency of aldosterone, there is positivity inside the lumen which resist positive anions to be secreted in the lumen and the negative bicarbonate to be reabsorbed. So overall what happened? There is metabolic acidosis and hyperkalemia. Metabolic acidosis and hyperkalemia. So now we will shortly discuss the causes of type 4 RTA. The first cause is true hypoaldosteronism in this there is actually the aldosterone is low, though it is further divided into two parts. First one is hyporenin. In this the renin is also low and the aldosterone is also low. Hyporenin, hypoaldosteronism. The causes are diabetes. The kidney is not functioning, so renin is not getting secreted and the aldosterone is also low. Because of use of NSAIDs and beta blocker also there is low renin. Low renin will lead to low aldosterone. Second cause of true hypoaldosteronism is hyperenin and hypoaldosteronism. This can occur because of the defect in adrenal insufficiency can be the cause. Or hyperenin hypoaldosteronism. This can be because of primary adrenal insufficiency or drugs like ACE inhibitor or ARB. In these two drugs there is increased renin. Renin is high. And ketoconazole and heparin also. It blocks the enzyme of the RAS pathway. Because of that there is increase in renin. So in all four causes there is renin is high, but aldosterone is low. So these two causes are of true hypoaldosteronism. What is now next is pseudo hypoaldosteronism. It can be divided into type 2 or type 1. Type 1 is defective ENaC channel. Defective ENaC channel. There is presence of aldosterone is present, but it cannot act because the channel of ENaC is defective. And in type 2 there is defect in NCC, which is sodium chloride co-transporter. There is defective sodium chloride co-transporter. Because of this increased sodium in the lumen, and the mechanism we have already discussed. And the drug which can cause this is spironolactone or amiloride. And the fourth one is CTIN. It is actually chronic tubulointerstitial nephritis. In this the aldosterone is. So now we will compare the different type of RTA we have discussed till now. So starting with the first one, serum potassium. Serum potassium is low in type 1 and type 2 RTA and high in type 4 RTA. Renal function is normal in type 1 and type 2 RTA. It can be associated with CKD in type 4 RTA. Type 4 RTA can be associated with CKD. Next factor is serum bicarb. Serum bicarb is on lower side in type 1 RTA, and it ranges from 16 to 20 in type 2 and type 4 RTA. Urine citrate is high in type 2 RTA and low in type 1 and type 4 RTA. Fanconi syndrome is associated with type 2 RTA. We have already discussed these things. Urine anion gap is positive in all type of RTA. And the urine calcium and nephrocalcinosis is associated with type 1 RTA. It is normal in type 1, type 2 and type 4 RTA. So guys, that is all we need to know in renal tubular acidosis.